Okay, thank you very much everybody for coming back in on time. So our second session is going to be about orthopedic disorders, and this one will be moderated by Professor Mudarris. Yes, Mudarris, sorry. He is very well-known figure for everybody here, I think. He's a professor of Macquarie University of Orthopedics, also a professor of Notre Dame University. He is an honorary professor at Sydney University School of Engineering. He's also the head of orthopedics and sports sciences at Macquarie University. And of course, we all know about his great leading pioneering of orthopedic surgery, especially in the knee restructure and the hip restructure. Please welcome him with me.
Thank you very much, Bassam. Sorry, I'm just recovering from a virus, so my voice is not going to be the best. Okay, so I'll talk briefly about the advancement in management of knee disorders. I do have financial disclosures, and these are my financial disclosures because I participate in design and manufacturing of several medical products. So I just want to announce that we are very proud to have a short stay program up here at Macquarie University, which is an initiative that is very unique, and it's kind of transforming medicine in Australia the way we knew it, and hopefully this model of care will open a window for many other centres to follow through, because that's the future, where healthcare is becoming more partnership between health groups and medical professionals to improve the quality of care for their patients and facilitate their recovery. So Macquarie is in the leading forefront of this advancement. So I'll start very much into the analysis of knee disorders. So you start with an X-ray, and a lot of the time I get patients coming to see me with this view, or now more often I get a patient coming to see me with knee disorder with an MRI, not even an X-ray. But we often miss what's going on with the rest of the patient, and this is a classic patient that presented to me with this deformity, and he had knee pain. He's coming for me asking for a knee replacement, and the treatment path for him was completely different because he didn't need a knee replacement. He had leg limb discrepancy, he had rotational malalignment, and he had significant deformity at the proximal end. So I ended up doing corrective osteotomy for him rather than doing a knee replacement, restoring his alignment. He never needed a knee replacement. He may in the future progress to having a knee replacement, but not necessarily anytime soon. He's very active, though he's in his 70s. When he goes to the gym, he runs, and he's moved on with his life. So a lot of the time we have focused on the area of interest where the pain is, while ignoring the patient as a whole. So the way we analyze and we look at the patient is as a whole. So we kind of run more comprehensive assessment for a patient, especially with lower limb, and it is vital to assess the patient from many aspects, because and mainly in a three-dimensional configuration and aspects, because that will give us more accurate assessment of the deformity, the structure of the limb and the joints in the lower limb, and give us an idea, a better idea how to manage their deformity. And a lot of the time, patients come to us with this kind of look on their leg. They're either straight, or they are knock-kneed, or they are bow-legged, and very commonly they all have pain in the knee, but their pathology is completely different. And when you look at the valgus, varus, malalignment, no one is the same. We all grow differently, and we all grow to some degree of deformity. No one has equal level, no one has the same rotation. As we grow in utero, our limbs forms, and as a result of that, that will give us the shape that we grow into, and that can be affected by the injuries that we sustain throughout the growth period. So people, we are all at risk of arthritis, and arthritis affects us above the age of 40. It's more commonly in women, more commonly with obesity and previous trauma, and certain ethnic backgrounds have higher risk of developing arthritis. Arabic population have very high risk of developing knee arthritis, less so hip arthritis. When you look at the African population, they get more arthritis in the hip. Japanese population, they get less arthritis than the rest of the world. While Chinese patients, they have more knee arthritis, which is very interesting. Anglo-Saxons, they get it both ends. Unfortunately, hip and knee arthritis is very prevalent in this population. And as you can see, we are living a lot longer. Throughout, there has been 2 jumps in the human population growth, and that is in 1850 with the Industrial Revolution, and then with the invention of or the discovery of penicillin in the 1950. There is another jump, and now it's expected that we will live to 100 years very soon. And that's because we're eating healthy, we're breathing healthy, and we are treating our heart conditions and diabetes much more effectively. So the factors that affect the outcome of a total knee replacement depends on 3 elements. It depends on the patient, and the patient is kind of a constant factor. Because it does, you get what you get, and you get the sick patient and you get the healthy patient, and they act differently. So it's not every knee get the same results. But the variable factors are the surgeon and the technology that you use, and that's where we can improve. The surgeon can improve with their techniques. The technology always gets better with time. When you get a patient, as a common presentation, they are a 40-year-old male coming to us with a medial meniscal injury. That's a very classic referral that I get into my practice, and a lot of the time they get surprised with the answers that we give them, because they're coming in expecting to have a knee arthroscopy or keyhole surgery to shave the meniscus off. Or they get a 25-year-old female with pain in the front of the knee. Or you have a much younger person coming with a meniscal injury or a dislocated patella, or you have an older, more senior female coming with both knee pain, or you have an older male coming with or brought by his wife or his children, forcing him to come with because he seems to have becoming less and less functioning lately, and he doesn't want to get out of the house. And this is the common presentation. Patients have severe arthritic changes in the knee, and usually the answer is a knee replacement. Knee replacement is the 25th most successful procedure ever invented in the history. Hip replacement is the 2nd most successful procedure after cataract surgery. So they are very good procedures, but are they good for everybody? Definitely not. And when you look at the trend, you look at total knee replacement, majority of patients who have arthritis get a knee replacement as a total knee replacement. Some patients get partial knee replacement or half knee replacement, and revision surgery is being very stable throughout the years from the National Joint Registry. And when you look at the growth of the National Joint Registry, you can see during COVID there has been a slight drop, and this is from the Australian Joint Registry. You can see the trend is going up and up. So we're getting a lot more joint replacements every year in New South Wales. And when you look at the graph, you can see that this line over here, which is the green line showing robotic surgery, is picking up dramatically. And people are using one or more sources of technology, and there are many factors that drive surgeons to do that. The main legitimate factor is because they believe in this technology and they find it more useful for their patient, but there are other factors that drive people to use technology, such as marketing, which are not necessarily, has an effect on the patient. But what's reflected clearly in the joint registry, which is a blunt tool because it takes a cross-section from every single joint replacement done in Australia, and you can see that the trend is clear that robotically assisted knee replacement is doing better, especially for the younger population, which is the harder group. And when you look at this, this figure shows it very clearly. You have the blue and the green lines are both related to the age group, and they are performing better than the non-robotically assisted technology. So what is a robot? A robot is a tool that we use. It has an arm, and that arm comes and helps you to have your cutting guides in more precisely positioned on the limb. It is like any kind of gadget as used with, it's not like robotic surgery using gynecology or neurology where the surgeon operating the robot from a distance without them being involved in the surgery. This is not the case with robotic surgery in orthopedics. The robotic surgery in orthopedics, the robot do the positioning for you, but you have to be doing the procedure. And certain robotic assisted surgery can do some of the cutting for you, but you need to be involved in the case. So we're not as advanced as doing robotic surgery where you can operate from home or from a different city while the patient is somewhere else. Having said that, it does involve a lot of preoperative planning and data entry into the robot, what can be analyzed, and that adds a lot of level of accuracy because after all, it's more carpentry. It's all about cutting a shape in space to high accuracy levels, basically. So basically, you get landmarks from the limb, as you can see over here, and then you analyze these landmarks, and then it all comes on the screen in front of us, and we check the position of the object, and then the robot put the knee replacement for you on the computer, and then you assess where you want it to sit, and the goal is to get the joint line at the same level that it was, or where you predict, and you get ligament balance, you get patella tracking properly, and you get the mechanical axis accurately positioned. And all these numbers get spat at you from the computer, and you have to analyze it very quickly as you're operating. And with time, you learn how to do it very like a second nature, and it becomes more easy to do, and it's not that hard. One main advantage of doing this is that you can minimize your instrumentation because this is the only instruments that I use for a knee replacement, as opposed if I use a different kind of technology like old instrumentation technology, you'll have 3 or 4 more trays, and that reduces the cost, reduce the time, increase efficiency, and reduce the risk of contamination. So there are advantages of doing this where it does help us in improving the outcomes. And then you have additive kind of information that you can help on the long run where you can monitor the patient after all. So we're all spying on our patients now where we hook them up with gadgets that will monitor their activity level. And you can see this is applied in many aspects of medicine, including cardiology, where people who have pacemakers or defibrillators, the cardiologists from home know about their patients if they are having any problems. Now, but is it the only solution? No, it's not, because a lot of pathologies come in to us where they don't need a knee replacement, and I'll show you the vast majority of our patients that come in can be prevented from having a knee replacement. And this is very important because as GPs, for example, as the first line of respondent to injuries, when patients walk in, they get to deal with patients coming in with anterior knee pain. It's very common, or patella dislocation, or a medial meniscal tear. All these pathologies, if they are overlooked, they end up with a problem that could have been avoided, which is arthritis. So if you look at the gait of the patient and they walk funny, like how many of you have children that have pigeon toes? And this is a major problem, because that indicates that these young kids have rotational malalignment and they need to be corrected. That doesn't mean that we need to correct every single rotational malalignment, but if they become symptomatic, they need to be corrected. Because the mechanics of the knee joint is very, very critical to be very accurate. You need the alignment properly working. At the same time, you need the patella that goes in the rail of the trochlea up and down accurately and not derail, because that will lead to abnormal forces going on the patellofemoral joint and end up with basically wear in the patella and then friction and later on arthritis. And you can see there's a classic example where you see patients have ligamentous laxity, hyperextension, valgus malalignment, the patella is tracking abnormally, and in the past this used to be treated with physiotherapy and end up with arthritis. Well, now you need early intervention. You can realign these patients, do a corrective osteotomy for this patient, relieve their pain, and improve their patella tracking, and maybe prevent them from having a knee replacement in the future. And the patella is the evil here. It's always, especially in females, patellofemoral disorder is very common, and if you can rectify that early in the days, you can prevent a problem. And it can go from the hip, where their femoral inversion is high, or the femoral torsion is high, or you have a lateral hypoplasia of the femoral condyle, you have valgus malalignment in the knee, you have external tibial torsion, or tibia that is valgus, or metatarsus adductus. And all of these can play a role in changing the forces in the knee and resulting in arthritis. So arthritis doesn't happen just because of an aging process. A knee cartilage should wear evenly, otherwise. If it is tracking well. And you can see here, look at the whole patient, okay, and look at if there is a significant injury, that's a different question, that's a different matter. But if it's repetitive, frequent minor injuries that lead to pain, that means there is something wrong with the biomechanics of this limb. And as a result of that, that can be corrected and prevented. So it is uncommon to see post-traumatic injury and instability in the knee because injuries heal. But it is very common that people have minor traumas that result to instability. And you can see this is a classic example of this patient with a malalignment in the leg. And as a result of that, any kind of simple rotational force can lead to this patient having significant patellofemoral maltracking, and as a result of that, repetitive ligamentous injury and ending up with severe abnormality. You can see these are kind of different presentation of patients. That's a severely pigeon-toed patient that will end up with serious problems in the future if it's not corrected. While on the other hand, and you can see in the kid, his patella is pointing inward, his foot is pointing inward, while his leg is straight. While this lady, the foot and the patella is pointing forward, but her leg is both significant, knocked significantly. And this is a classic example of how the patella can J-track. So by simple observation to these patient pathology and alignment, you can diagnose them very easily and make an assessment without needing of running through extensive investigation, MRI scans, etc. And the solution can be simple. Always examine the patient, look at them, Okay, see how much they rotate with their leg, because it's very important to look at the abnormality, and it's very clear to assess it and identify it and treat it basically. So this is all what I mean, we do a lot of 3D modeling and 3D scanning with the technology that we have available to us now, because all these images, engineers with a special format of materialize can 3D reconstruct the limb and put it to us. And there is a lot of work that we do in conjunction with engineerings now, where we can look at the structure very carefully and assess it very accurately, and able to correct the malalignment. And there are things that you can do in childhood where you use certain measures like these growth control plates, where you allow the one part of the body to grow while the other part is holding off, and that can correct the alignment with time and prevent future problem.
2 minutes.
Yeah, well, pretty much done. And you can see this is a classic example of how 3D modeling is done, and can be presented to the patient very clearly. And it's very good when the patient understands their pathology, so they can be part of the treatment and part of the solution for their problems. Thank you very much.
So our next speaker is the Associate Professor Yasser Al-Khatib. He's an orthopedic surgeon with a particular clinical interest in hip replacement and revision surgery, knee replacement and revision surgery, and the management and the treatment of trauma and sports injuries of the hip and knee. He has obtained his medical degree from the University of New South Wales in 2003 after successfully completing his training. Dr. Khatib was awarded fellowship of the Royal Australasian College of Surgeons 2011, and then he went to travel to Toronto, Canada for a fellowship in hip and knee surgery. Can I jump for it? So, and then he's now a senior clinical lecturer at the University of Sydney School of Medicine, Nepean, and is actively involved with undergraduates and postgraduate students.
Thank you for that warm introduction. I actually something, but thank you, appreciate it. Okay, so good morning. Thank you for being here, and thank you for the invitation to speak to you about management of conditions around the hip. And the aim here is to have it at a very broad level. Essentially, as a general practitioner, what can you do to have an idea about what's happening around patients who present with hip or buttock pain? Okay, so the hip tends to lend itself to this kind of approach, because if we consider a few factors, we can narrow down the diagnosis of the conditions that we're dealing with. Hip conditions tend to categorize themselves very nicely based on age and location of pain. And if you take into account a few other symptoms, then we're pretty much home. It can be daunting to think about all the potential differential diagnosis that can come around the area, but essentially if we think about common pathologies that happen in certain ages, we can narrow down what's happening, and then we can also consider pathology particular to the hip itself or pathology around it. So for example, in infancy we worry about issues with dysplastic hips leading to dislocation. In childhood, it's more a vascular necrosis of the hip, which is known as Perthes disease. And then in adolescence, we start to come into patients who are more active. So we worry about issues with slippage of the femoral epiphysis. And in early adulthood, we tend to encounter issues with arthritis, labral tears, and what's known as femoral acetabular impingement. And of course, as we progress through middle age, we start to get more conditions related to tendinitis, and of course in older age we start to see arthritis more commonly. So if we look at a child, and that's the first thing that we'll talk about here, is mainly related to developmental dysplasia, which is still something that is picked up in general practice. especially with infant screening tests like the Ortolani and Barlow test, where essentially you're assessing a child for a clicky hip or a clunky hip. And of course, it tends to be more common in firstborn children, in females, especially if they have a family history of the same occurring in previous siblings, or if there was a breech presentation. And it's important to pick this up because early detection can lead to rapid treatment, and of course, missing a condition like this can lead to lifelong consequences. In terms of the investigations, it really depends on what stage of development we've picked this pathology in. So early on, the hip joint itself is mostly cartilaginous, so it's not really a lot of point doing x-rays. We tend to diagnose using ultrasounds to have a look at the coverage of the hip. And then as the child becomes older, there is more ossification of the hip center, and you can see here, for example, there is a difference between one side to another. We can see that the hip kind of looks like it's in the vicinity of the sternum, whereas this hip is obviously more outside. And there are a bunch of little radiological markers that we can look to see if a hip is inlocated or not, but essentially that's what we're looking at. And does the hip joint look like it's in place? And of course there are other tests that are more, I guess, invasive, especially in a child, like an MRI scan or an arthrogram. They're mostly used by surgeons because they do require a general anesthetic in that age group. So if we're looking now at an infant, let's say between the ages of 2 and 10, who presents with hip pain, and the vascularity can be compromised around that area, leading to what we call Perthes disease, which is essentially interruption in blood supply to the femoral head, and that of course leads to fragmentation and remodeling around the hip joint itself, but unfortunately it doesn't remodel in a normal position, so that leads to hip pain, thigh pain, stiffness, and eventually shortening as the head starts to collapse. As the child grows into adolescence, we start to worry, and they become more active, we start to worry about things like split capital epiphysis of the femur, where essentially the top of the femoral head, which is a point of weakness because there is a developing growth plate over here, which is cartilaginous and soft, tends to fall off the hip, essentially like an ice cream falling off the cone. And it tends to displace posteriorly and inferiorly, and of course that's associated with pain, a limp, and can affect the patient later on, and we'll come to see that in a bit. In adults, it's a little bit more useful to ask about where the location of the pain is, and there are 3 typical locations: anterior pain, lateral pain, and buttock pain. Typically, the anterior pain tends to be more intra-articular pathology related, and there's this classical sign that a patient comes to tell you when you ask them where is the pain. They'll put their hand around their hip like that, and you know that's more related to hip pain, and we tend to call that sometimes a positive C sign. They're telling you exactly where the pathology is, and they've done half the job for you. And sometimes the pain can be radiating down to the thigh, and we start to worry about issues related to the hip itself. So we went through some of the childhood conditions. Of course, if the hip recovers from a childhood condition, it may not heal in exactly the same position, and you may develop little abnormalities around the hip, such as development of a little bump around where the head joins the neck, or abnormalities in the development of the acetabulum, which is the cup part of the ball and socket joint, and that can lead to abnormal contact forces between this part of bone and this part of bone. You can imagine that flexion and abduction or adduction can tend to cause impingement in that area. Now, of course, between those 2 bony surfaces and around the hip, there is this structure called the labrum. The labrum essentially seals off the hip joint and becomes a bit of a seal of the joint and a little bit of a cushion. So, of course, if that's caught in between 2 abnormal surfaces, you're more likely to get a tear. And labral tears are common, especially in middle-aged young adults and middle-aged adults, especially in females, especially with new onset exercises or repetitive activities. Patients tend to describe a popping or a clicking noise, a catching pain, and pain getting out of a chair, so extending up from a flexed position. Labral tears are commonly around the anterior and superior part of the labrum. A lot of them are incidental and sometimes aggravated. So if you just have an MRI scan of somebody who has a vague history and you get a labral tear, it's not necessarily the labral tear that's causing it, but there may be some aggravation, because you'll start to see this more commonly as people are accessing MRI scan for initial investigations. It's common in certain sports, and the mainstay of diagnosis here really is with an MRI scan. And as MRI scans have become more of higher quality in terms of imaging, MR arthrograms, where dye is injected into the joint, are becoming less common. So you can see, for example, in a hip like this, it's not completely spherical anymore. There is a bit of a bump around this area, and you can see how this and this can impinge together, leading to damage of the cartilage or the labrum in between. Of course, another common reason for sudden pain, and this is a more acute, more sudden, more painful condition, is avascular necrosis. And just like Perthes disease is interruption of the blood supply in the femoral head in the child, avascular necrosis is its equivalent in an adult. But the big difference is a child has a lot of healing potential, growing and remodeling, whereas an adult is pretty much done for growing and remodeling. So all you get now is death of the bone that supports the cartilage, which then leads to collapse of that bone, which then leads to a dysfunctional joint with collapse of the cartilage. It is a common condition. It accounts for about 3 to 5% of hip replacements in Australia, and it's common with increased alcohol use, steroids, so steroid prednisone medication in long term, high cholesterol, and then other conditions like radiation or chemotherapy. And patients will come in and they'll tell you exactly on what day their pain started, so it's very sudden, they know about it and it's very sore. And it's the usual kind of algorithm for investigations. Initially we start with a good set of x-rays, followed by an MRI scan. X-rays can show you a lot of features, but you'd have to examine them carefully. So for example, you see a little crescent sign where you get a little bit of a white line that develops underneath the cartilage, and that usually is a sign of bone collapsing around that area and remodeling. So you get nice new sclerotic bone, except it doesn't give you the adequate support for the cartilage anymore, so the cartilage over it becomes essentially like a gibraltar wall on a wall that's full of termites. It doesn't really work very well. And of course, if you did MRI, you'll see where the area of bone necrosis is, and that's the zone of collapse. So unfortunately, that's not really reversible, except if you had a small area of involvement. So in that case, you can try to stimulate healing by doing what we call a core decompression. And maybe you'll appreciate a few drill holes through this area. And this is where we've tried to drill the hole, essentially to stimulate some bleeding into it, decrease the pressure inside the bone, and allow it to regenerate some new bone. But you can only do that in small areas. You can only do it when there isn't collapse. So for example, we see over here, we don't really have a big crescent sign. We don't have that white line that was visible in the last x-ray. And of course, if it's beyond that, then we're looking at arthroplasty, and arthroplasty is hip replacement generally. And as Munjid said, it's a very successful operation. It's the second most successful operation after cataract in terms of restoration of function to patient. Last century, so it was named as the operation of the century. And hip replacements tend to do really well, even with the older models of hip replacements, and technology has changed a lot. But even with the older models, about 90% of them tended to survive over 17 years. So they do reasonably well, especially in particular pathology. So you can see that not all hip replacements tend to survive the same. Osteoarthritis tends to happen in older adults, less, I guess, functional demand, so the chance of revision is lower. And whereas we look at something, for example, like avascular necrosis or osteonecrosis, and it's slightly higher. So it does depend on pathology. And of course, more recently, there have been a lot of new surgical approaches that essentially have aimed at decreasing the acute recovery phase, so less pain acutely, early discharge, early mobilization, early rehabilitation, as Munjid has shown, fairly similar to what's happening with the knee. And you can see that recovery is shorter and quicker, especially in the first 6 weeks. The overall survival doesn't tend to change much, but the earlier recovery is a lot better. So we don't have patients walking on frames anymore. They tend to be fairly independent by 6 weeks, able to do most things, walking around with little limp. So that has advanced significantly, and pain itself reported after surgery has definitely changed. Okay, so that was a general view of anterior hip pain. And the next common thing is lateral hip pain, and this is more of a middle-aged female kind of presentation, because there's increased incidence of what we call trochanteric bursitis. So bursa is just a fluid-filled soft tissue structure that tends to line joints and muscles and allows them to function with minimal friction on the overlying skin and soft tissue. And you can see with a lot of repetitive activity, so up and down stairs, or exercise, or general activities of daily living, you can get irritation in that area. You get tendinitis of the two main muscles that support your hip, which isn't actually the gluteus maximus, that's more just for show. It's the muscles underneath it, the gluteus medius and minimus, that stabilize the pelvis with every step you take. And so if there is tendinitis or a tendon tear, then you are likely to experience limping, pain, and then inflammation around the area, which can commonly get diagnosed or misdiagnosed as isolated trochanteric bursitis. Usually bursitis is a sign of what's happening underneath rather than the problem itself. Of course, there are many other structures around the hip, and one must not forget to exclude nerve compression as a source of pain, especially with the lateral femoral cutaneous nerve that comes straight out of this area and can cause pain and numbness around the lateral aspect of the hip. And diagnosis sometimes is complex, but other times it can be as simple as performing a Tinel's test, which is percussion along the course of the nerve, and if that reproduces the symptoms, then you've pretty much made it. Common signs that I'm sure most general practitioners would know: Trendelenburg sign, where if you have failure of the abductor mechanism to support the pelvis is no longer level, so it tilts. And of course, if you're tilting your pelvis with every step you take, then you have limping, you have pain, that puts pressure on your back and can exacerbate your symptoms. And then the other examination tests over here are more at isolating where which part of which muscle is involved, because there are a few muscles around the same region, and physios tend to be really good at doing that because they have a keen interest in their anatomy. And management, again, is to exclude arthritis, exclude the dangerous stuff. So it tends to be arthritis, fractures, metastases, cancers, that sort of stuff. Ultrasounds are commonly used in general practice, and you pretty much universally get one diagnosis, which is trochanteric bursitis. It seems that everybody has it, but really the benefit is limited. MRI tends to be the mainstay of diagnosis here because it tells you if there is tendinopathy, if there is a tear of the tendon, if it's come off the bone. Commonly, this is treated with corticosteroid injections. However, when you examine the evidence, it actually is very sketchy around corticosteroid injections into the area. And to be honest, if you compare them to physiotherapy alone, they're probably equivalent in the longer term, so 3 to 6 months onwards. There is treatment that's called shockwave therapy. To be honest, I don't think that's commonly used over here. Some physiotherapists tend to use it, but essentially what you need is to strengthen the muscle, treat it as if it's tendinitis. Core strengthening exercises tend to work, but you need to modify the activities to avoid the activities that are causing soreness. Surgical repair is sometimes possible, especially if a tendon is completely torn and displaced from the bone. And physiotherapists will commonly tell you about posterior buttock syndrome or posterior or deep buttock pain, and will diagnose issues like piriformis. Piriformis is a muscle that is intimately related to the sciatic nerve. The sciatic nerve can pass through it or can pass around it. So you can imagine that if you have tendinitis or traction of this muscle, which is an external rotator of the hip, then you can get irritation of the sciatic nerve. And that can commonly be confused with sciatica, can be commonly be confused with lumbar spine pathology, and I'm sure Dr. Ali will talk to us about that later on. Ischiofemoral impingement is also one of those syndromes that you'll hear about from physiotherapists. But most of the treatment for these conditions really is with physiotherapy and activity modification. I've tried to stay to time. Thank you very much.
Thanks, Dr. Aokaby. Now we're going to have Dr. Ali Ahmad. Of course, no, I don't.
Okay,
Would you like that?
No.
Yeah.
So, look, my name is Ali Ahmad. I'm a spine surgeon. Currently I work at the Alfred Hospital. I do trauma orthopedic surgery at the same time. I do spine, and also work at the Austin Hospital where I do mainly spine. And my private practice is called Momentum Spine, which I see my private patient. So I finished my orthopedic training program in Baghdad Medical City in Iraq, and then I come to the Australia here to do a spine fellowship at Royal Adelaide Hospital. This is in 2007, and then after that I did the orthopedic training program in Victoria. Then I did the spine fellowship at the Austin. Then I went overseas to do a spine fellowship at Washington University in St. Louis, Missouri, and then came back. So I just want to, my talk today is about aging spine, and at the end also I will talk about what the new happening in the spine for a period of time. So what is the aging spine? The spine is the optimal functional age for the spine is between the age of 15 to 25. After 25, everything go aging. Regardless, every one of us have aging spine. The spine is just aging due to the load. So what happened when we 30s, we start having a problem like this bulges and this touch the nerve, and you see people with this age, they come and present it to you with a sciatica, which is pain in the back radiated down the leg. And this is the common presentation in those age group. And then when we reach into 50, what happens is we start having facet disease, we start having more of a back pain and leg pain, and because of when you have a disc bulge and degeneration, what happens, the disc height will really collapse, and then the facet not lining up anymore. They're not congruent, and then you have wear off. Whenever two surfaces not parallel, you will wear off. The 90 to 95% of the population, I call them the favorable ankylosis of the spine. They have a favorable outcome. They have ankylosis, but then they don't have symptoms, or they have a back pain which is tolerable and they could manage. So this is the favorable outcome. 5% of the people have unfavorable ankylosis or degeneration. When they start having stenosis, which is central stenosis, or spondylolisthesis, or even the more advanced, which is the deformity, which is the high end of the spine problem. So we'll come. This is a stable ankylosis. All of us, like when we pass 50, will have a spine like that. So there is a lot of arthritis everywhere, but we're still, like the facet is okay with no nerve rotation. We're still managing and pushing it through. Then when progressive collapse happens, we have a spondylolisthesis, and then we start have foraminal stenosis, and then a neurogenic claudication. Whenever we walk, we have to sit down, and this is the unfavorable type. So this needed treatment. And then if we push through, then we end up with deformity. We start getting like tipping over and really not able to maintain our like position or our alignment. So what the clinical presentation of patient with back pain, normally they present to you with a lower back and also radiculopathy. This is the common presentation you will see. Look, lower back is a bit difficult for me to manage. If you ask me how many patients you operate for a lower back, I really would say the finger of this hand, a year of back. And I tried everything, throw everything on them, and if it doesn't work, then back pain. Because it's like, you operate on those one, you just trade one back pain and you give them another back pain. So trade pain with pain, and then, so you try everything before you operate on those one. The problem is when this becomes radiculopathy, and then you see the patient start what they call it, reduce their walking distance, modify their activities. They use the car more than they walk. So you see them in the shopping center. The first thing they look for is the trolley, because they want the trolley because they bend forward, and this gives them a bit of release of neurogenic claudication, because more space for the spine to the nerves when they bend forward. And then after that, they push through, and then when they end up with weakness, some unsteadiness, and they fall, multiple falls. And this is classical history. And if they still they don't have a treatment for that, they will start have postural problem. They tipping forward, and they can't really maintain their position. And then ultimately they will have like a bowel and bladder symptoms, and all is like consequences of not treating their condition. And you see here, this is the cone of energy. So the spine is really, if your head, in the center of your head, over the center of the pelvis, over your center of the feet, this is energy efficient. Patient walk without needing any muscle to contract or anything. When you tip forward, the problem is the back muscle try to bring you forward. And if you do this, then those muscles will get fatigued at the end of the day, because they all the time they're contracting, and they will have upper back pain. Or if they don't do this, then they do even flex the hip, flex the knee to try to bring the head backward, and then they will start having arthritis in the hip and the knee. So it's all going bad from there. So examination, you examine them, you look for like a weakness in the leg. Also, you look for any sensation, sensory loss. You have to document this one. And the most important is the posture, because when they come to you, they look like the posture is okay, but when you ask them to really straighten the hip and the knee, they will go forward. So this is also important, and then you try to address that one. Plain film really hardly used. I mean, it's good to follow up fracture to see the alignment is maintained. Apart from that, it doesn't really give you any information. I don't use them at all in my practice, to be honest, unless post-op to check the implant and everything and follow up, but it's not really used. The most important thing is to get X-ray of the hip. If you're in doubt whether the hip or the back, get X-ray of the hip, because a lot of cases you think it's the back, but they have hip arthritis. And this could be tricky. So even get an X-ray of the pelvis, look at the hip, make sure they don't have arthritis. CT scan useful. It shows you the bony anatomy, plan your surgery if we need it later on. You see this patient has spondylolisthesis and also degeneration L5S1 and spondylolisthesis, which means the spine move forward. You can see here the spine is moved forward compared to the one below. And also it also, when you have a previous decompression, you see where is the hole they created in the spine, and you plan your surgery. So CT is a good investigation. The most important one is the MRI. So the MRI show you the changes. You look at this. This is a normal disc if you look here, when you look at the MRI. So it's black at the back, black at the front, and it's gray in the middle. This is a normal looking healthy disc. You see that one, getting a bit changed, like black. When they black, they mean it's degeneration now happen. You see this bulge here, same here, and there here, even lost height. You see when the height of this disc compared to this one. When they lost height, mean the facet not lined up, and then they have mechanical back pain. You look here the same. Here a bit this bulges, and when they have this extent of bulge, it really touch the nerve and give you radiculopathy going down the leg. And this is the symptoms you have. When you refer patient to me, really, you refer the patient for surgical care, is they have low back pain with radiculopathy, mainly. If they're just back pain, I mean, you try to, either you or me will do physiotherapy, will do injection, some pain medication. Refer him to pain specialist is better than refer him to a surgeon, because this have to be all done than surgery with the mechanical back pain. And even the aim of surgery is not to cure the back pain if it happened, is to just make the back pain is more tolerable that he could function with. And then the other indication that they have back pain or and radiculopathy with the neurology, like they have foot drop, so this is an indication to send. Any mechanical back pain which you try to treat, you send them here and there, you send them pain specialists, physiotherapy, hydrotherapy, they done all these and no management, no improvement, then this one also you refer to see if there is anything we could help with. Back pain with deformity, the spine have scoliosis or kyphosis, whether a coronal problem or as a sagittal problem, so this one also you send, and also spondylolisthesis, because spondylolisthesis, although they are sometimes they don't have leg pain, they tend to progress with time. Even degenerative one, they tend to progress with time, and it's better we know about him early and know him before anything. And also deformity, progressive deformity, they can't really function, they can't do their normal daily activities, and they medically well people, then this could benefit possible from surgery. I mean, this all depends on a lot of tests we do later. So what changed since the operation? I remember growing up as orthopedic surgeon at Baghdad Medical City, helping Dr. Sabhan Khdairi and Dr. Ahmad and also Dawood Alrubaie. At that time, we do all back surgery all the time, one after the other, 5 a day in Baghdad Medical City. And all of them, posterior surgery we do. But then now things changed since then. So there is, you could approach the spine from really the back, from the side. You could approach it from the front, just mainly retroperitoneal approach, and then you access the spine depending what the problem. However, till now this is going all around. But then, if you ask me, I really do mainly posterior spine surgery. The guys I work with in WashU, on Washington University, they invented the anterior approach to the spine, but they said, we're not doing any anterior anymore, we just do posterior, because our skills in doing posterior surgery is so good. We could remove vertebra fully without needing to open the front. And also the consequences of going from the front, like you're going to open the chest, you see the lung, you see the heart, it's all good and nice. But then this is consequences. The patient have a pleural effusion, have chest infection, it's all have a problem. And also you do the abdominal retroperitoneal, they have hernia, they have a problem. So if we don't have to, we don't go. But I go anterior approach for one thing is like is a burst fracture. Those bad fracture, car accident, they come. Like this patient, for example, is one case I brought. So this patient, 28, he have a car accident, high speed, and then he neurologically intact. But most patients, although they report neurologically intact, they will have a bladder and bowel symptoms due to S2 and S3 injury, which is very common. But during the trauma, in a trauma setting, when you have them in a trauma assessment, you can't really test for bowel and bladder. They have the catheter anyway, so it's really later on it declares itself. So you look at this one, burst fracture, severe retropulse fragment going posteriorly. And if you go from the back, you go from the back, the nerve will be here and all traumatized, dural already trauma, and then you're trying to fish this fragment from the back is really cause a lot of harm. So those one I do anterior approach. And the anterior approach, I put the patient to the side, I use a table which break in the middle, and then you just find out this fragment here, you see here, this is the fracture, you can see it here, this here, and then here is everything removed. So this whole space, so you remove it, retroperitoneal approach, and then you, after I remove it, I just put a rod and a cage. This cage, because otherwise if you remove the vertebra, they will collapse, so you put cage to support it, which is just a spacer if you like. And then you put the rib just to achieve fusion and a lot of bone. And then flip the patient on the back and fuse it from the back. So you do construct like that one. It's also preserve movement above and below. And if you see here, you see that patient, the same patient, but the fragment is gone from the back. And you see here a lot of bone to stimulate fusion around this area. The posterior approach, as I said, is the main approach. We call it working horse for spine surgery. So see, example, how we do. What are the common presentation come to us? This bulge with radiculopathy. That type is the best patient you could have. Is radiculopathy going down the leg, because with those patients, when they come to me to the clinic, I normally try to get them, if they don't have radiculopathy and not in severe pain, you give them injection of the nerve root and send them for physiotherapy. However, if they recur and they keep coming and stop them, is really, I have a low threshold offering a microdiscectomy. The reason is a safe operation, take about 40 to 45 minutes you do this operation. You're not changing the patient who he is. You're just making a small hole in the spine using microscope, removing the disc, free the nerve. And this will never go back. So it's just, there is no point leaving the disc there, and they have significant functional improvement. Different from fusion. Fusion, when you fuse the patient is different. When you have a fusion, mean a segment of the spine not moving, mean he moved the one above and above more to compensate for the fusion. And this results with the progressive more fusion with time. So this one, you give him injection, nerve root, you send him CT guided, and see how he respond with the physio. If not, improve microdiscectomy operation and use the microscope just to clean up the nerve. And they really have a good functional outcome, unless they are like have a secondary gain compensable, like sometimes word cover, and they always tend to have pain and keep going. Yeah, this is different. So when you see this one is a bit different. That one, you see here wear and tear. There is not only a disc. You see there is a facet disease. There is a ligamentum flavum here. You see hypertrophy. So this is a different. You can't just do microscopectomy and expect that one to get better. So that one you have to do a bit bigger. Like you have to decompress the spine. You have to stabilize the spine and do fusion, unfortunately. But this one also, you tried everything. You tried whatever possible. But hydrotherapy, physiotherapy. Look, as a spine surgeon, at the end of the day, the first consultation with the patient, you know this patient will need surgery or not. But it's better for the patient and for yourself to try everything else, because even the patient, if he end up with a little bit of pain, he said, look, I tried everything. I tried physio, tried hydro, tried injection. It didn't work. Then I come to surgery. Accept it better, and yourself also. If you have infection, unfortunately, you feel guilty because why I should have tried this, I should try that. So it's better to try everything. But first consultation, I know this patient will need surgery or not, because it happened over and over. So this patient, see, I sent him for injection, but that one different. You do epidural, not a nerve root injection, is epidural injection. Here you do this one, and then see if it doesn't improve, then you do the operation. So what the other new things, navigation, robotic. I believe strongly in navigation. I don't like the word robotic in the spine, to be honest. And the reason navigation is like, because when I was in Washington University, we look into the screw placement. They do routine CT scan after every patient having surgery. And we look at the freehand technique, putting the screws all freehand, about every 10, if you put 10 screws, you have 3 screws out. So it's 74% accuracy. So this screws is dangerous. You put it medially, going into the nerve. You put it wrong lateral, you go into the arteries, the aorta, and everything. So it's not really. So it's not acceptable to have a 74% accuracy. While in navigation is almost 90-95% up to 99% accuracy. And this is, we're talking about best hand, like a spine surgeon, like Lawrence Linke, Dan Rowe, and those people. So you have to use navigation nowadays. And I think in 5 years, if you don't do navigation, you are risk of litigation. Robotics. So what is different? Navigation is you use image guidance, like CT scan, come out around the patient and help you to do an accurate placement of the screws. While robotic is the same thing, but then the robot with the screws. I rather put myself screws under navigation because I could use my experience. When things doesn't make sense, I could stop it and I check again. While robotic, you just press the button, is going that way. You can't really change it midway through, so there is a risk, which I think is unacceptable to me, although a lot of people do like a good job with robotic. So I don't have, myself, I don't do them, but people could do them accurately. So this is what happened. The patient come, this is one of the cases in Warringal Hospital in private I did. I have the C-arm, so this is the patient asleep. The C-arm, which is the CT scan, come over the patient, take a scan, and there is a, you see here, this is the tracker. So this is correlate the 3D position of the spine. And then is my fellow here. You see here, you could place the screw accurately. See how it's nice, like anyone could put screw. You can see here, you could put it in the bone. You're not damaging the nerve here, you're not damaging the vessel. You see the vessels here? It's accurate, and you can see the level of screw placement. So it's quite useful. And this is, you see here in the pelvis, it's so accurate across the sacroiliac joint. You see it here up to, you could put it really nicely and accurately and safely. The second version is to do 7D. Like this, you do a pre-op CT, the patient not sleep, you pre-op CT, and then you use what they call it like a facial recognition, if you like, something similar to that. When you expose the spine, they take a picture and then they correlate and you place them. I like the first one more than that one, to be honest, and I use them 100% navigate all my spine. And this is, will give you the picture, and then when you do with this technique, this is how you put the screw. So it's quite accurate also. Yeah, and I just want to go, yeah, some cases like this one have a disc bulge. He went for a discectomy somewhere, and then they have a look like a dural tear or something, and then another disc bulge. Then when they come with the second disc bulge, you can't really go and do a microdiscectomy again. Half of the disc already removed in the first operation. The second, you remove the half of the disc, then it will become like bone and bone. You will never be happy. So in this case, it's called fusion.
2 minutes.
Yeah, fair enough. And this is another case. You see how the navigation is helpful. This is like osteogenic sarcoma. You see in the top of here, refer to the I looked after him at the Austin from St. Vincent, and you can see here, when I did the fusion, you look, if you don't do it navigation, this is a 5 millimeter, and you put 5.5 size, and you put in 5 millimeter screw. How you could get it accurate in C1? So it helped you a lot. And this is the same patient after the operation when you have a radiotherapy. Yeah, this is the same thing, and you do fusion. So this is, I want to talk about that one. This is the high-end things, deformity. Unfortunately, the scoliosis, when you have someone like that, it's really the high-end problem, because everything different from children. Children with scoliosis, everything going for you. Adult with scoliosis, everything going against you. It's like similar. You have a distal radius fracture in children, even if they are 70-degree angulated, you will take an X-ray in a year, you will see completely healed in a straight position, because the body of the children, like they try to heal and remodel, while the adults, if there is injury, they tend to degenerate, which is work against you. So here you work against a stiff spine, and children is a flexible spine. Here the spinal cord tolerance is low. The children have very good tolerance of the spinal cord, and also the bone quality is good, because to correct this deformity, you need to put a screw to move the spine. The bone quality is not good, the children is good. So it's everything, but then you have those patients come to you, you have to do something about them. You can't just leave them, they can't function, they can't walk, they are healthy otherwise. Then either you place them into nursing home or you do operation. I do really about 5, 6 maybe of those a year, because they're expensive. The implant costs a lot of money. They stay in hospital long. They go to ICU. I don't do them in private. I do them in public. I do them Austin normally, and sometimes the Alfred. I have fellows to look after people. I have a big team, few registrar and physio to pack up, an ICU back up. So they need a full system. See this before, how bad the spine, and you see then they need neuro monitoring. They need, as I said, a long construct fixation. You can't just think that a small, this is a big problem. You can't really fix a big problem with a small operation. You have to do a big construct and big fixation and then line up their spine. This is the last thing, disc replacement. What I believe in disc replacement, look, unfortunately disc replacement, when the spine have a problem, degeneration, the natural history for the spine, they try to fuse, and they have autofusion if you look. So if you try to do disc replacement, it's something like you're swimming against the current, or you're swimming against the storm. You're trying to change the natural history, which is a bit difficult. However, if you look, the spine have a 3 joint. The disc here, the front, and they have the facet joint at the back, 2 on each side. So it's very rarely to have arthritis only in the disc with the facet normal, as I said. So then you put a disc replacement at the front, all fine and good. But then what happened to the back? They still arthritis and they still moving. So the patient, you make sure that this operation sometimes, make sure the patient's still in pain for a while, because the disc is not good. Well, if you fuse them, at least you get rid of the pain. However, there is indication for that one. If really the facets are okay, the young patient, mainly the cervical more than the lumbar, because the cervical is less load compared to the lumbar spine, and you do disc replacement, they function. Younger patient with one disease, facet is okay, they still, and if they fail, you could convert them to fusion. And that's all.
So I have to present on behalf of my colleague Mustafa Al-Tahir. Unfortunately, he couldn't attend today because he had a family emergency yesterday evening, and he even had to leave half the way through his list, so it is unfortunate. But Mustafa is, I talk about the Lion King and the animal kingdom actually, and he's Simba, basically. He's going to be the Lion King very soon, hopefully. He's very talented. Mustafa is young. I've known him since he was an intern. He was my intern in Liverpool when I first finished training, and I could see a spark in his eyes. And he's very skilled surgeon. He's Australian trained. He went to Fairfield High and came to Australia at a very young age with his family, not dissimilar to many of the Iraqis, and he managed to go through the training in Australia, and then he did 3 fellowships, 2 of them in Sydney one with us, one with foot and ankle surgeon in the eastern suburbs, and then he did a fellowship in Switzerland. He's a very talented limb reconstruction surgeon. He has special interest in foot and ankle surgery, and he's the brain in our unit basically. He does a lot of the engineering work with our engineers. So I will be giving his talk, if it's all right. Okay, so we're talking about ankle problems. 90% of ankle arthritis is secondary to trauma. And it starts very simple with ankle sprains. You twist your ankle, you ignore it, you go to the GP, you go to the physio, and you strap it, and then it gets better, and then it doesn't feel as stable, and then you twist it again, and it hurts more, and then it gets better, and then you twist it again, it hurts more, and you keep ignoring it until you start having constant pain, and that's when the problem hit. The ankle is a very, very complex joint. You have the knee is like four times the size of the ankle, while the ankle is tiny. It's a small territory, small area where the talus articulate with the tibia, and it's like a dome shape or a rectangular shape joint that is highly constrained from the bony structure, has very little small amount of cartilage, and has ligaments on the inner side and the outer side of the ankle that are extremely vital. Unfortunately, it can get affected very heavily by our collagen disorder and by the way we are. So if you are flexible, if you can hyperextend your knees and you're double jointed, you are prone to have ankle injury. It's very common. The cartilage in the ankle is half of the cartilage in the knee, but it's more robust and more sturdy. But when it gets injured, it doesn't recover as much. So it is very common that when you get a twisting injury to the ankle, you injure the cartilage, and that cartilage injury becomes permanent. Ankle sprains are extremely common. It's pretty much the most common injury a person have in their sporting time. And a lot of the time when you get a fracture, you get cartilage injury. The fracture heals very well. It can heal anatomical, but the cartilage injury remain and cause problems, and it goes downhill to develop arthritis. So it's very easy to assess an ankle injury. You just check a range of movement, and you just move the ankle, and you see how stable it is. Look at the elbow of the patient, see if they extend their elbow, look at their fingers, if they hyperextend, then you raise the index of suspicion that these people could have a permanent ligament sprain. It's usually the ATFL, the CAL, or the deltoid ligament that can be sprained. And if it's a chronic sprain of these ligaments, then that lead to long-term arthritis. If you have the tibiofibular ligament strained or ruptured, then that's a syndesmotic injury. And if that gets missed, then you get sued, because that lead to very rapid acceleration of arthritis. And patient within 3 months, they get bad problems. So you need to be very careful not to miss a syndesmotic injury in an ankle. And then you look at the alignment. If you look at the patient from the back and their heel is twisting outward, and if they have flat foot, a lot of people have flat foot. If it becomes painful flat foot, that's a major problem, okay? And that needs to be addressed. Before starting to do foot and ankle surgery, we used to ignore every single flat foot comes through the door. But Mustafa has taught us a lot about his experience in Switzerland and the way the Europeans are moving and the way science is evolving with foot and ankle management of deformities, and a lot of arthritic changes can be reversed and can be prevented basically. And you can see this is a classic appearance of an ankle arthritis that could have been prevented just by correcting the deformity. And it's like anything, if you plumb line and everything is going in the line of and the geometry of The mechanical access, it should wear evenly and it should last longer time, and it shouldn't lead to uneven wear and arthritis. And if it get caught early and you diagnose it in the early stages before permanent damage occurs, the solution is simple, which is just by reconstructive surgery and just tightening or reconstructing these ligaments. And it's a keyhole surgery that you can avoid the major problem later on down the track. And obviously other measures that you can do for preventing progression of the disease, like weight loss, physiotherapy, strengthening exercises, overcoming the problems that these patients suffer from, then you can do deformity correction. There are a lot of things that you can do by correcting the deformity if it's a flexible deformity. You can see this case, for example, as a chronic deltoid instability, and the ankle is twisted, and by just reconstructing the ligaments, you can put the foot underneath the ankle and make it straight, and as a result of that, you can change the biomechanics of this ankle and extend their lifetime with their ankle without doing ankle replacement. It looks horrible, doesn't it? But funny enough, that salvage this ankle and prevent this patient from having an ankle replacement or ankle fusion or even amputation later on. Arthrodesis is the most common treatment for ankle arthritis in Australia, and that's because people don't know better. And as limb reconstruction surgeons, especially in our unit, we say amputation is better than arthrodesis, because arthrodesis is a major, these joints are designed to move, okay? Yes, you can fuse the ankle and the pain will go away, but you transmit the forces to other joints that are moving and you create a problem elsewhere. And it's similar to the spine. You fuse one segment, you transfer it to the level above, to the level below. It's exactly the same with the foot and ankle joint. Joints are not designed to be fused. So if you can salvage the joint, please do so. If you can replace the joint, if it's terminal arthritis, that's a better solution. But fusing the joint is the last thing. And there are certain indications for joint fusion, but they are narrower and narrower now with the advancement of the treatment that we have. And you can see here, ankle replacement had bad name in the past, and that's because people didn't understand how ankle replacement worked. And it's similar to hip replacement when it started, similar to knee replacement when it started, and now with better understanding of how the foot and ankle biomechanics work, if you treat the ankle as just the ankle joint that is arthritic and you replace it in its condition without correcting the deformity, you'll end up with a disaster. But if you correct the deformity around the ankle, then replace the joint, you will have very happy patient that has very long-lasting ankle replacement that can survive many years. And the technologies that we use is, as I mentioned, we heavily rely on 3D printing and analysis of the images that we get, and we rely on communication with the engineering department in order to build up the precision tools to make us apply and implement the procedure and the implant in a very accurate position. And these are classic jigs that we use for ankle replacement in order to position the joint in a very accurate place. And you can see, for example, this is a classic picture where the patient had a subtalar shift, like a heel shift, in order to get the plumb line down through the mechanical access in order for the forces to be applied on the ankle joint evenly without compromise. Because the last thing you want is to have something like this, where this patient has been operated on had an ankle replacement without correcting the malalignment and ending up with loose ankle, and then we had to come back and then revise it into more proper alignment and fix the deformity. And we have developed solutions for ankle deficiency as well. I mean, I get accused that I just want to chop off legs. As a matter of fact, I try to save legs more than anybody else. So we have this technology now where even if there is a complete talar necrosis, where the talus has vaporized and disappeared, and we can replace parts with 3D printing, and we have the technology, and you can see this patient had an ankle replacement somewhere in Melbourne, and unfortunately the talus become necrotic and everything sunk. So what we did, we put a cement spacer in the place as a stain surgery, built up the height, and then manufactured a 3D printed implant for this patient. You can see this is the design process that we go through, where the engineers go through the processes, and we build models for the patient and have the replacement design. This is all done by Mustafa. Basically, amazingly, he stays awake in my offices in Ride with the engineers till 4 or 5 a.m. in the morning, and building these designs. And you can see that's building a talus, and then we can implement it. And he does make us look good, basically, because you can see the results. We build an ankle without. This patient came to us asking for an amputation, but we can salvage him. And we build an ankle for this patient. Basically, that's another example where the talus was spat out in the street, basically from a dislocation, and had an ankle, had a talus replacement somewhere else, and then we just changed that and failed, unfortunately, and we built a new design and put the new ankle replacement in this patient, and it worked very well. So there are solutions now with the advancement of engineering technologies to provide better solutions for foot and ankle surgery than we ever had, and the aim is to relieve pain, restore mobility, and correct the mechanical malalignment. Thank you very much.
So can I ask Dr. Munjid, Dr. Yasser, and Dr. Ali, please, to come to the panel, and we're going to have 15 minutes of questions and answers.
So I have a question to Dr. Munjid and to Dr. Ali. Dr. Munjid, kids with tibial torsions, there is an age where we need to refer, and where is an age we can say to wait. And for Dr. Ali, scan showing central canal stenosis, is that any significant to refer to a surgeon?
Yeah, so for rotational deformity for children, I would wait until they are coming toward puberty. I mean, depends. If you have pure rotational deformity without angular deformity, then I would wait till their physis coming to close, because you don't want to affect the physis. If any derotation, if you do it at a younger age, you need to put a plate, and that will be harder because they will be in a wheelchair. But ideally, you put nails in them, so you want them you want their growth plate to stop. If they have angular deformity, then they need to be referred much earlier, because you can do with 8 plates where you can do growth arrest or temporary growth control for their bone as they are growing. So utilize their growth potential to correct them, rather than cut them and correct them. So ideally, the referral depends on what deformity they have. With any angulation, refer early. With rotation, purely, you can sit on them a little bit.
Dr.
I think there's a second question.
I think this is with spinal stenosis, it's more of treating the patient than the scan. So typically if the patient is symptomatic, like normally with the spinal canal stenosis, the symptoms is more of a neurogenital education. So whenever he walk, he have a calf pain. Whenever he sit or for a few minutes, the pain goes away and then he keep going. So the stress become multiple step. So this is indication of referring because this is a symptomatic problem and it tend to progress with time. The problem with the scan, you know that we have a lot of, all of us will have some spinal stenosis around there, but if they are not asymptomatic, then I think we just leave it and watch it. Even if they're symptomatic, the first treatment with this patient is to get them into, especially if they are comorbid, like they have a lot of diseases and they have a big list of medication. So those patients give them epidural injection and give them hydrotherapy and see how they goes. If they're still symptomatic after that one, then they may score surgery. Otherwise I think I'll just watch.
I've got a question for Dr. Yasser. You talked about developmental dysplasia of the hip, and you mentioned ultrasound scan. What's the age when you think that ultrasound scan is not very good imaging and we should do maybe an X-ray? What's the cutoff age?
So the real use is in the screening phase, so postpartum. So within 2 months it's pretty useful. After 6 months, there's very little role for ultrasound because you start to get ossification of the center of the hip. So you're better off using X-rays beyond that.
So 6 months is the cutoff.
Right. So mostly it's used for initial screening. And so after birth, there is usually a pediatric screen. If a newborn child is noticed to have a clicky hip, that's when you do an ultrasound. Potentially for the first 6 to 8 weeks afterwards, you can follow up the result of that with ultrasounds. But let's say the child is now 6 months, then I would just head straight towards having an X-ray.
Sorry, would you still do an ultrasound scan if the Barlow and Alrubaie tests are negative, but you see some bit of a difference, asymmetry in the skin crease?
Yes, I would, because the downside of missing a dislocated hip or a dysplastic hip is high, especially in the early period of development where it's quite salvageable with simple measures like splinting, like spikers. So yeah, I would.
And with the, you also talked about liberal tear. That's a little bit sometimes difficult to find even on MRI scans, is that right?
Well, no, MRI now is like looking at a TV in 4K ultra high definition. You see stuff that you don't know what to do with. There's a lot of incidental stuff, and the skill now is not picking up those things, it's deciding when to ignore them.
And, sorry, one last question.
I can guarantee you that more than 20% of people in this room have labral tear. So labral tear is not an indication for surgery. And we had, Yasser may agree with me here, because we went through a spike where every labral tear gets surgery. And there was a massive spike of hip arthroscopies in Australia. And now, I'm a hip scopist, and I can tell you I do less than one hip arthroscopy every 2 months nowadays, because you need to pick your patients. And the majority of hip scopes are indicated not for a labral tear, it's for femoral stamen peak. And the labral tear is like a meniscal injury that is stable.
Sorry.
I deliberately left off the surgery for labral tears because of that exact same reason. So 10 years ago was the next big thing, and it was going to be a miracle operation, and it didn't pan out that way. And really the indications are limited.
One more question for the answer. Impingement, hip impingement. What's the best imaging? X-ray? Would you pick it on X-ray or CT?
Again, it's X-rays will show you when the hip is out of round, so where you have a bump. And again, going back to hip arthroscopy, that's the bit that's most useful is to shave off that bump, and that's a reasonably predictable procedure. And once you've made the diagnosis with that X-ray, then really the MRI, the use of MRI is more for the surgeon to have a roadmap for what will they do and will they mark surgery or not. For example, if you have significant chondropathy that you can't appreciate on an X-ray, but you can tell on an MRI scan, that may persuade you against surgery. Right? So I would say as a screening test, as a general practice type of test, I would just go with a series of X-rays, which is an anterior posterior view, lateral view, perhaps add a semi-lateral or a done view, which is done in flexion. Most radiology places will be able to do that for you. If they report a significant bump, then I would refer on, and then perhaps MRI should be done by the surgeon.
Sorry, one last one. I've got 2-minute question. Sorry about that. One last question to Dr. Ali. This pouch, would they heal? Like if you just send them to see a physiotherapist, and would they heal?
This bulge, if you talk about radiology, they still abnormal. But if you talk about symptomology of the patient, they would heal. So if the patient comes to you with usually present with a disc bulge, they have radiculopathy. So this radiculopathy, you give them injection, you give them hydrotherapy. If they symptomatically improve, then I will not worry getting the MRI again, because it doesn't change my measurement. I will not let someone who's asymptomatic for any further treatment, isn't it? So it doesn't really change. However, when the annulus they happen, because the annulus, the disc, if you look at the disc in cross-section, the annulus fibrosis are the periphery and inside the nucleus pulposus. So what happened, first, if you ask any patient with a disc pain, with a disc problem, he will tell you, I lift something, I have back pain to start with. This is where the annulus happened, there in the annulus, back pain. Then after 2 or 3 days, I start to have pain going down the leg. This is when the nucleus herniated from the defect in the annulus, which is a weak point. So even if they heal, they will never heal as strong fibers as the annulus. So they heal with a scar tissue. And this is the problem, whenever they lift something, whenever they function, then they will have a herniation. It's a weak point. So he improve. Unfortunately, I see it all the time. They improve, they take time off work, 6 weeks, to get physio, hydro, go to the water, do the things, and then they get better. Then they go to work, and before you know it, like after 3 months, they have the same symptoms. And no one could afford, especially young people, that every time, you can't employ someone that every time you take 6 weeks to recover from a disc. That's why I saw when they have recurrence, then you consider surgical option. This is more of a permanent solution to get them up and going.
Thank you. Dr. Amir?
Thank you. So my question to Dr. Munjid, I would like to ask about your opinion of OA, the risk of OA after the ligament reconstruction, knee ligaments. Especially if we compare it with non-surgical treatment. Especially there's a research from University of Melbourne, and they found that there's a good result. We treat the ligaments by rehabilitation in the surgery, and they found the MRI findings really good, and they think that the risk of OA in future will be less.
That's a very, very good question, actually, because that's exactly what I tell my patients. There is no evidence to show that ACL reconstruction or, as per matter of concern, PCL reconstruction would prevent arthritis. As a matter of fact, the sequelae of events, the minute you rupture your ACL or PCL, you injure the meniscus, that's arthritis kicking in, whether you're reconstructed or not. The only reason in my practice for me to do an ACL or a PCL reconstruction if the patient has instability. It's not to prevent arthritis. If the patient feels unstable, and they want to go up and down ladders and they want to be highly active and they can't run and do the pivoting and shifting activity they want to do, that's when I operate on them. But it is wrong to say that this will prevent arthritis, because no matter what you do, arthritis will happen to these patients. So the indication for ACL reconstruction is for instability only. I don't know. Yes, sir.
Yeah, and the indication for surgery is not to prevent arthritis, it's for stability. So if you have a tradesperson out in the West who can't go up and down ladders, well, it's a no-brainer, they're going to need an ACL reconstruction. The best that you can deduce from ACL reconstructive surgery is you may have protective mechanism to the secondary stabilizers, which are the meniscus. So to prevent further damage over time to that. But whether you do ACL reconstruction or not doesn't really change the natural history.
Thank you.
Dr. Ahmad.
Just quickly, in a general practice lab, what's your first imaging for any of the joints, and what's the gold standard imaging? You know, a lot of time, patient came to a specialist for an MRI because the general practitioner can't. So for all of you, what's the first imaging you prefer for your joint, and what's the gold standard at the best? And then one just for our general practitioner colleague, for the avascular necrosis that Dr. Yasser mentioned. We have some medical risk factors that you follow up. People with chronic pancreatitis, people with liver transplant, and people on bisphosphonate. It's widely used, everyone used. They should be monitored for avascular necrosis.
Thank you, Dr. Ahmed. I would say in orthopedic teaching, a series of x-rays in at least two orthogonal views, so 90 degrees to each other, is an extension of our examination. I would discourage from high-powered investigations like MRI. I think they produce more confusion than use in general practice setting. We see a lot of degenerative meniscal tears and things like that referred with an MRI as the first port of call when it comes to investigations. And then I tend to work backwards, so send a patient for an X-ray and they've got near bone-on-bone arthritis. So in fact, there was very little point of a $500 spent on an MRI scan. And the other thing I would discourage is repetitive use of ultrasound. I see a lot of ultrasound in knee and hip, and it is very limited in what it can offer you. And it will tell you there's fluid, and if you do an examination of, especially a knee where it's more obvious, you'll see the fluid. And that's really about it. And I think everything beyond that is more a subspecialty type investigation. Unless you're concerned about tumors or something like that, where you're doing a CT scan or an MRI scan for that particular reason. But other than that, I would just give them X-ray.
Yeah, I agree with you, sir. I mean, X-ray is the gold standard, and as a limb reconstruction surgeon, I do hip and knee surgery, and I always do long extending X-ray or an EOS scan. It's important to see the alignment, and especially if you have minimal changes. But X-ray is definitely what we need. MRI scan, I would discourage anyone from doing an MRI scan as a first line, and try to avoid using ultrasound, please, unless there is specific indication for it. Ultrasound is only useful in very, very specific, limited indications, extremely limited indications.
Yeah, look, I think this one is a little bit different. So if you have a patient that have a radicular pain or nerve pain or weakness, I think the only investigation really is the MRI, because X-ray doesn't help. For sure, I don't use them, I don't look at them. The only X-ray I look at the X-ray of the hip to see if they have arthritis if you were it. CT scan, radiation without benefit, because anyway, when you send them to really, I would not look at the CT scan, to be honest with you. I just send them for MRI if they have a neurology, because I want to see the detail over there, where's the compression is. I can't really take patient to theater or consider surgical option. So you're giving them radiation, which is for an investigation, which is not useful. However, I understand there is a bit of charge with the GP. I don't know if some of the patient will give the GP order the MRI to cost the patient a bit out of pocket or something. So that's fine. Then don't really do any test. I'll just send it to me. I could order the MRI.
Question to Dr. Ali. Often we receive those patients with the among like teenagers about scoliosis. So what's the best approach for that? And sometimes we send an X-ray and we come back with Aokaby angle degree, like what's the angle definition, and how do we approach those patients, and what's the ultimate?
Yeah, so the definition of scoliosis is a cup angle of more than 7 degrees. It used to be 9 degrees, 7 degrees. So before you say there is a list for scoliosis, it has to be more than. So often you see some patient have a few degrees. I think it's just a normal, like 4 or 5 degrees. I would ignore that one. But if it's more than 9 degrees, depending on their age, what we do. If the child, for example, 13 years old or young, then you send him to the children's hospital or a pediatric spine surgeon. If the child, I would say 14 or 15, and the cup, even 14, and the cup ankle is not big, because no one, the treatment of scoliosis, if the scoliosis is less than 25 degrees, we treat them with nothing. Between 25 to 40 and 45 degrees, you brace them, and if they are more than 45 degrees, you operate, because those people, we know that they will progress 1 degree a year, and if they are 45 degrees, then they will go big. So if the angle less than the angle high, and they are like young, then send them to pediatric, and if they are old, then you send them to a spine surgeon, adult spine surgeon.
Thanks, Dr. Ali. The last question.
The last question was to Dr. Munjid.
He's gone.
Regarding the replacement of the talus, artificial talus, you are immobilizing. You are immobilizing or retaining the position of the talus with screws to the calcaneum and navicular. So roughly this is a triple arthrodesis.
Correct.
So how much is it going to affect the right spine or the ankle?
Yeah, so this is, so these are special indications when you have total talar failure. So if you have avascular necrosis of the talus where you can't utilize the talus, or if you have conditions where the talus is, you have multiple revision surgeries in the past where the talus have no bone substance. So you have to bypass that to the talar navicular joint and the talar calcaneal joint or subtalar joint. The main joint in this area is the ankle joint, the main mobility. The rest of the joints around that area have very little movement. So transmitting the force to these joints is not as damaging as if you fuse the ankle itself. That's your question. But when we do ankle replacement purely with ankle arthritis, we don't fix the subtalar joint or the talar navicular joint. We leave them free.
So do you advise ankle replacement in patients have triple arthrodesis, or in the third world there's a lot of polio and they are treating the foot with the triple arthrodesis? Do you advise this, or?
It depends. Again, I see them here actually because a lot of them are migrant and they come to see us here. So if they had the triple arthrodesis, then yes, definitely if there is movement in the ankle. But if they don't have any ankle function, then then it is a difficult problem to treat. And I've done a few ankle replacements on polio patients. It's much more tricky because if there is no power that operate this ankle, then it becomes useless. Okay, so you need some power to operate that ankle. That's very important.
Okay. Thank you very much for the questions. Thank you, Dr. Yasser and Dr. Ali. So we will be breaking for lunch. Just before that, Dr. Ahmad will...
Just to mention that all these sessions will be recorded and they will be on Facebook, on the YouTube channel that we have, the organization or association YouTube channels and other. So the network for this will be wide, very wide. Not only that. Thank you very much.